Well, thank you for that great welcome, and it's good to see everybody here this evening. I have to say, I feel very privileged to be asked to come and give this talk. It's quite unusual, I think, to have many opportunities in your career to be given a totally blank sheet to speak on. And it was great just being asked to come and give a lecture. But then you sort of think, well, actually, there's so many different things. How do I choose what it is that I want to focus on? So I've decided to focus on the subject of vulnerability, because I think that's something which, for me, goes across all specialisms within nursing, across all care settings. And hopefully it's something which all of you will, you know, as we go through the sort of session, be able to sort of see the links to your own area of interest and practice. Just to sort of put it in context, I just wanted to start by sort of saying, I suppose really sort of my personal journey. And you know when you're always looking for clip art and you're trying to find the right one? I think that is right, because there's lots of loops and twists and turns in this. But I suppose the real start for me was going back to when I started doing my PhD way back last century, where basically I started off with a very clear idea of what I wanted to do. I wanted to look at policy and how that impacted on disabled people generally, maybe specifically people with learning disabilities. And one of my earliest memories of doing my PhD is about 2 weeks into the PhD, we had a postgraduate session, and that we were going around the room, and everybody was sort of saying where they were with their study. And I was all of 2 weeks in, and I was quite clear about what I wanted to do and how I wanted to do it. And as we went around the room, we started to get to people who were sort of saying, well, I've been at this for a year, and I thought I knew what I was doing, and I've completely lost where I am. I don't know where I'm focusing. And I could see some people who were recognizing this in the audience. And I thought, well, this is odd, because I've been doing this for 2 weeks, and I'm quite clear. But of course, at that time, I didn't know what I didn't know. I didn't recognize some of my assumptions that I carried with me for a number of years, some of the things which I hadn't questioned. And I focused on looking at oppression, and when I started to look at how we do research, it became very clear to me that there was a danger of what I wanted to do was actually research oppression and discrimination in ways which might be seen as oppressive. And so I had to completely rethink what I wanted to do. But it started me questioning, started me thinking about and challenging, I suppose, some of the things which I hadn't previously looked at. I then, probably about 2003, something like that, wrote an editorial for a journal I was working on then, Learning Disability Practice, and I focused it on vulnerability, because I became aware lots of people were talking about vulnerable groups, vulnerable people, and it's like, well, what did that mean? And for me, the sort of point I made within that editorial, and I think I probably would nuance it a lot differently now, really was actually being vulnerable is not an inevitable consequence of having a learning disability. It's something else. There's something much more complex going on here that we should understand. In my teaching, I sort of inherited a master's program where I worked as the award leader for a number of years, and that was around professional practice, but with a particular focus on vulnerability. And that was a great sort of privilege and a great pleasure, because I worked with practitioners, some quite experienced practitioners, people perhaps who were senior nurses in safeguarding roles, things like that. And over a number of years we worked together and really sort of trying to critically examine some of these issues and to challenge some of this. And again, I learned an awful lot from the people that were in the classroom. We had people from very, very diverse nursing backgrounds. I think we probably had about every specialism that there was within nursing. But that was great, because we all challenged each other and we all learnt. In my research, I've worked on a number of projects, and I suppose one where vulnerability was a particular issue was a project looking at abuse and people with learning disabilities. And we did that as a participatory study. And the reason we did that was because people with a learning disability, that we have an advisory group in my university, and they said, we want to do some research and we want to do it about abuse, because actually we know that we've been abused or our friends have been abused, and nobody asked people with learning disabilities about it. And there seemed to be almost another level of vulnerability. It wasn't just about the abuse, but there was also the vulnerability in terms of your experience not being recognised, your voices not being heard. And so I suppose it's something which I've tried over a number of years to think about in terms of writing. And I've returned to it recently as well because a colleague and myself published a book around safeguarding a few years ago, and we've just been doing sort of the second edition of that. So that's maybe go back into some of this. And I think that's where there's the twists and turns, because it's not a direct line, and I would say it's something which I'm still very much thinking about, very much developing, and hopefully what I want to try and do within the time I've got with you today is to encourage you to also look at it critically. So why vulnerability? I quite like this quote because I think it really sums up some of the problems which we have. It's one of those words which we use quite a lot in practice. We talk about vulnerable patients, we talk about in research, we talk about vulnerable groups. Until fairly recently, we've had policy and legislation around protection of vulnerable adults. People at this time of year, there's lots of discussions perhaps around people being vulnerable to the flu. We need vulnerable groups to go in. So it's one of those terms that is commonplace. But I bet if I went round and asked each of you, which I haven't got time to do this evening, to sort of give me your definition, there would be slight differences. Yeah? And I think what I like about this is it sort of catches this bit about assuming that we know what it means. We assume that other people understand it in the same way that we understand it. And I think that's where we need to be a bit more critical. We need to challenge it. We need to challenge our own understanding and understand that maybe other people might look at things slightly differently. I couldn't put it onto a slide for this, but there was a lovely sort of picture I saw on Facebook today, which was, it was the number 6 that was written, and people were looking at it from different sides, and one person was saying that's 6, the other person was saying that's 9. Yeah? Same thing, but actually people were looking at it very, very differently, and the comment with it was, we need to understand other people's perspectives. And I think vulnerability is one of those issues where we need to think about it. And I think part of the problem is this. This isn't a quote from nursing, it's a quote from Zen and the Art of Motorcycle Maintenance for those of you that are interested. But I think it's quite an apt one in this context, because I think what makes vulnerability so difficult to understand isn't its strangeness, it's actually its familiarity. It's because it's something every day, we take it for granted. We don't think about what it means, and we don't try and sort of look at it critically. Obviously, a lot of people have tried to define this. There's lots of stuff written about this. If you look at a lot of the definitions, what is common to most of them is this idea of harm, danger, threat to the individual, the idea that it could be physical or psychological. But there's also a very sort of strong strand within the literature which says actually it's a contested term, people have got different views. Does that actually imply a weakness in the concept? If it does, what are the implications of that? One of the ways in which it's used, we talk about vulnerable groups, and that's particularly true within the context of research, but it's also in the context of practice as well. So we talk about people with dementia, people with learning disabilities, people with mental health problems, children, people who misuse substances, prisoners, older people, minority ethnic groups, disabled people. I could go on. People who are unconscious. There's a whole range. In a way, I suppose that's a convenient shorthand. We talk about vulnerable groups, and there's both strengths and problems with that approach. In terms of the positives, I think one of the things it does is recognise that within society there are certain groups of people who perhaps have been at greater risk or have been subjected to various harms in the past. So if you think about that in the context of research, for example, it's used as a shorthand because if you're putting in things for ethics committees, people want to know, are there vulnerable groups involved? And that's because some quite horrific things have happened in the name of research in the past. And those things have quite often happened to groups who might be considered vulnerable. So people with learning disabilities, people with mental health problems, prisoners, people like that. Issues around capacity, consent, coercion, all running through those. So because of that, I suppose it seeks to provide some kind of protection. It's a recognition that there is an additional risk there, and therefore other people perhaps need to step in with some kind of protective role. You could look there at things like the protection of vulnerable adults. Yeah, we have a group of people, if they meet certain characteristics, we have particular policies which maybe are there to safeguard their well-being. It acts as a sensitizing concept as well. Now, it's quite difficult because, we work in busy areas, we have lots of people coming through, and it's quite difficult sometimes to understand everything about every individual. So, in a way, it almost acts as an alert. If you have somebody in who has this condition or belongs to a certain group, you think, maybe I need to think about X, Y, or Z. So it's quite helpful, maybe, from that context. But there's a lot of negatives which go with it as well. The notion about stigmatizing and labeling, it's almost like, othering people. There's them and us. There's us and there's these people that are vulnerable. Interestingly, when I said that I taught on the master's course a few years ago, I asked them to work in groups to look at the notion about research and vulnerability and split them into different groups to look and say, well, okay, what are the questions you would come up with? What are the issues? There was the group that were the sort of ethics committee. There was the group that there were the research funders. One group were the group, if you want, of vulnerable people. When I got feedback from them and said, okay, so what did you think the issues were? The first thing they had on their list was, who says we're vulnerable? And I think there is this notion about stigmatizing. Certainly in terms of the policy, we've moved away from protection of vulnerable adults because people felt that it was maybe stigmatizing, this notion about it being a problem within the individual. Goes on to the second point, this locating vulnerability in presumed individual characteristics. It's this notion about if we look at people, then it's almost like you're inevitably vulnerable. If you belong to this group, X, Y, or Z follows. Ignores within group diversity and multiple identities. I said to you about the research which we undertook around abuse. One of the people that still sticks in my mind from when we were doing the interviews was a young man with learning disabilities who came from a minority ethnic group. And he talked about how when he was in learning disability settings, he got abused and bullied because he was from a different minority ethnic group. And yet when he was with other people from his ethnic group, he got bullied because he had a learning disability. We don't, when you look at those vulnerable groups, people often have a number of those. So how do those operate? How do they interact with each other? Maybe reduce autonomy. Because people think it is about protecting people, sometimes we have, don't get me wrong, we have to work in people's best interests at times, that's clear. But sometimes people they see a group characteristic or a presumed group characteristic and treat everybody the same. If I give you an example of that, a number of years ago, my mother, because I lived a distance away, she fell. She had to go from hospital into a nursing home for a short period of time for rehabilitation. And the first week that she was there, she kept getting asked by the members of staff, well, when's your next of kin coming? She said, well, at the weekend, my daughter's coming up, she works. So when I went up at the weekend, the nurse came in and said to me, and I have to say before anybody panics, this was before the Mental Capacity Act. The nurse sort of said to me, oh, can I have a quiet word? Okay. So we go into the office and she said, oh, can you just sign to consent for your mother for these things? And the first number of things were things like, I think it was having her washing done, having her hair done or something, and having a photograph taken for the files. So I sort of said, have you not asked my mum? Oh, no, we tend to ask the next of kin. I said, well, actually, I should ask her. So in the end, I convinced the person that they should ask my mum those, but they said, but there is one thing we need to ask you instead. Okay, what's that? Well, if your mother collapsed, do you want her to be resuscitated? And I sort of said, but I think that's a conversation you should have with my mum. And, well, we wouldn't want to upset her. So I sort of said, well, I can assure you actually it would upset my mum a lot more if this conversation had gone on and she wasn't involved. What had happened? They'd actually looked at, usually people that came into that nursing home were quite frail. Sometimes they were confused. And so they hadn't seen my mum. Somebody who was, needed some physical support, but mentally was extremely alert. To the point when we went back in and we were talking with the sort of nurse and sort of saying about, do you consent to have your photograph taken? And my mum signed, she said, yeah. She said, that's fine. She said, but it's a pity you didn't ask yesterday when you took the photo. Nice one, Mum. Okay. And obviously you can see from that it can work against the provision of person-centred care because we make assumptions about people. You know, age, we talk about older people, extremely diverse group. We talk about people with learning disabilities. That could include somebody who is married, bringing up their children, through to somebody who's got very complex needs, who perhaps can't communicate verbally and requires total support. There's a lot of diversity, and yet this label, vulnerable groups, sometimes gets in the way of seeing the person. So, okay, who is vulnerable? There's one view that it's actually people who are in extraordinary circumstances that are vulnerable. But there's another view, which is actually everybody is. It's part of being human. This second study was, it was some work which was undertaken where they actually asked nurses and carers about their views about vulnerability and how they felt about it. And they came down, when they analysed the data, it was about being human. Selman has done quite a lot of work on this and talks about it being part of being human. Yeah, it's self-evident, it's part of the human condition. But he also recognises that there are times or there are people who are perhaps what he calls more than ordinarily vulnerable. It's something additional. He also makes an interesting point, though, that actually feeling invulnerable can increase vulnerability. And usually when I've had discussions in the classroom with this, the examples we've used is those of you who have teenage children, who nothing is, the world is theirs, nothing's going to happen to me, I'm invulnerable. Or even, the people where perhaps we might give health advice, where we think actually you could be, no, absolutely not going to happen. There are dangers in not recognising vulnerability. So we need to consider that as well. So if everybody is vulnerable, where does that then put nurses? If it's an inevitable part of the human condition, then by definition, nurses are also vulnerable. Selman argues that he wouldn't put us in the category of being more than ordinarily vulnerable. He sort of says, okay, we are vulnerable as part of being human, but we don't have this additional vulnerability which perhaps other people may have. But there's a debate in the literature about that, with some sort of saying, actually nurses are vulnerable by virtue of being human, but there are also additional vulnerabilities associated with the nursing role. Some of the experiences which we face, some of the difficult situations which we face, can actually put nurses in a vulnerable position, whether that's physically, which sometimes people are. We know that there are instances of, if you want, aggression, violence and aggression within certain settings, but also psychologically dealing with some of the issues. Dealing with other people's vulnerabilities, can remind us of our own vulnerability. And I think, it's quite interesting with this other one comment, it's both a burden and a resource. It is something which can be quite difficult to deal with, but in the context of caring, recognising our own vulnerability can actually be a resource and a basis for us providing that caring. And I think that's sort of contrary to perhaps what has been traditionally focused, keeping the stiff upper lip, got to be professional, not letting our vulnerability show. But actually that can have a cost on people. I mean, hopefully we're shifting away from that, but it's not so long ago that perhaps was the ethos which people were expected to adhere to. Hofmeister also says it's a source of our concern for others. It's also a source of our interest in and reliance upon others. Our common vulnerability bonds us and binds us to other people. And I think that's one element which I'd like you to hold on to as well. This notion about our common vulnerability and how that actually provides us with a resource in the context of nursing. There's been a lot of debate, there's been a lot of sometimes bad press about nursing practice over recent years. People have been concerned about a lack of dignity, a lack of compassion, some quite high profile examples of abuse. And if you look, I think this is quite an interesting issue when we look at it in the context of this and vulnerability. If the aim of nursing practice is compassionate engagement with patients, vulnerability cannot be conceptualised in terms of patient susceptibility alone, as though it was a risk factor that could or should be eliminated. It's an ever-present aspect of being human, and recognition of mutual vulnerability is a way to preserve on a societal level the value of caring for others. I think it's not just about preserving it at a societal level. I think it's about at a practice level. It's about us recognising other people's vulnerability, recognising our own, and using that as a basis for developing truly sort of person-centred care. So a different way of looking at it was, rather than sort of saying this person is vulnerable, we have vulnerable groups, vulnerable people, is actually just to ask ourselves a question: what is this person vulnerable to? And there are some traditional things which perhaps we might recognise. So we would talk about, quite often in a nursing context, people, perhaps immunocompromised, immunosuppressed, being vulnerable to infection. At this time of year, we talk about people being vulnerable, as I said, to the flu. People living with long-term conditions may also be vulnerable to long-term or chronic pain. But start thinking more broadly, start thinking about the whole range of things which people might be vulnerable to. People can be vulnerable to discrimination. In my field, in terms of learning disability, there have been some quite high-profile cases of where poor care or a lack of care has been provided, and that has resulted sometimes in death, sometimes in high levels of suffering. And that has quite often been because sometimes of discrimination. Discrimination that's not always, if you want, conscious, but sometimes discrimination which is perhaps built into the way in which we provide services, the way in which we respond or don't respond. I've come across sometimes in the past where we talk about equality, for example, this notion about it's okay because we treat everybody the same here, we don't discriminate. But if you don't treat people differently when they have different levels of need, you end up discriminating because you're not meeting those individual needs. So, that's where we're talking about, maybe the person with dementia could be very vulnerable to discrimination, sometimes because people will see things as having worth or not worth in terms of interventions. People may be vulnerable to discrimination in terms of access to treatment. There's a whole range of things there which people could be vulnerable to. And of course, again, think that doesn't just apply to patients and families that we're supporting, can also apply to nurses. Marginalisation. People being pushed to one side, maybe not regarded, not seen as being perhaps the same worth as other people. Being vulnerable to a lack of control. Classic one in the context of health, isn't it? I mean, how many of you have been admitted to hospital? And one of the first things that you feel is things are out of your control, isn't it? Other people are in charge, things are happening, things like that. It can be issues around, for example, somebody who is a wheelchair user, who has their own wheelchair, who it's electric, they can get around fine. They go into hospital and they can't have that wheelchair in that setting. And all of a sudden, they're very vulnerable because they don't have the capacity to be independent in their movement as they would in other settings. Think broadly with this. We know that, a lot of the people that we work with, a lot of long-term chronic conditions are linked to poverty. People are vulnerable to poverty. And there's also links with other things. If you're poor, you're more likely to be disabled, and if you're disabled, you're more likely to be poor. And all of that will have an impact on your health and well-being. People being vulnerable to exclusion, not just marginalisation, but being totally shut out of settings. So, a whole range of things. As I say, I would encourage you to think broadly about what it is that people are vulnerable to, and hopefully you can think of a lot more than I've just put up there. There's other dimensions that we have to think about. There's the notion about, is it actual vulnerability or is it potential vulnerability? Sometimes people are in situations and they are vulnerable, but other times we work with people and we can predict that there could be certain vulnerabilities. Or there are certain settings where they can be vulnerable. Those are things, if it's potential, there are things where we can actually, hopefully, work to reduce or eliminate that. The importance of time and context. Things can change very rapidly. People's level of vulnerability can go up or down very quickly just because of the sort of passage of time. Context. People may cope very well. Somebody who is sight impaired, for instance, may cope very well at home. You put them into a different setting, and it's quite difficult because they're not used to where things are. you know, for people with dementia. You know, we take somebody who perhaps has a high level of confusion and we put them in the context of hospital wards, which can be extremely confusing places. Yeah, in a way, we can increase their vulnerability. There's also the idea about objective and subjective. So in that paper, going back as far as 2000, distinguishes between the ETIC and EMIC views, so the internal and the external. And also, he sort of says, you know, we need to explore the lived experience of vulnerability. It provides a different sort of perspective. You know, that paper is looking at Gypsy Roma travellers, where they're labelled as being, by the people as being vulnerable because of certain health conditions. But when you talk to them about how they saw vulnerability, it was in terms of things like discrimination, oppression, and marginalisation. So you can see how, you know, both need to be taken into account if we're to work productively with people. Also, I mean, what about the situation where, as professionals, we assess somebody as being vulnerable, but they don't feel that they are? You know, in some settings, there are particular implications. I mean, I think if somebody perhaps has a mental health problem and they're a danger to themselves or others, then there's legal actions, or legal interventions which we would have to take. But you can get situations where people don't see themselves as vulnerable, and yet as professionals, we think they are. We should be intervening. We should be doing something. You can also get the flip side of that. Yeah, as professionals, we feel that people aren't vulnerable. They don't meet our criteria for vulnerability, and yet for themselves, they feel extremely vulnerable. So think about other dimensions. Heaslip says that, you know, it's a bit like, you know, the familiar definition of pain. She would say that it's similar to the experience of pain. It's exactly what the individual experiencing it says it is, and they experience it when they say they are. Yeah, we need to understand, we need to think about, and we need to take on board the patients, the individuals, the family's view about vulnerability as well. The Department of Health did some work on this in relation to safeguarding, and they provide quite a useful framework. They talk about 3 elements that we need to think about. So there's the personal circumstances, and they give some examples there: disability, mental health, illness, frailty. The environment and the risks within that environment. And it's quite interesting, you can see there in terms of the environment, it's not just about the physical environment, it's talking about things like social contacts, it's talking about quality of care, the physical environment, and also the resilience factors within an individual, their capacity to cope with some of these risks and stressors. When we were writing the book around safeguarding, I tried to sort of build on some of that and came up with this definition. It's not an inevitable consequence of certain personal characteristics, but rather the complex interaction between the physical and psychological characteristics of an individual and their physical, social, psychological, and economic environment. Since it's not inevitable, vulnerability can be reduced and potentially eliminated where it's deemed to be harmful. Because remember, a certain amount of vulnerability actually may be quite helpful if feeling invulnerable is a problem. I have to say, this is what I'm saying about sort of, you know, looping thinking and developing thinking. In terms of the new edition, I've added time and context into that because I think they are important elements when we're thinking about vulnerability. So, trying to put all this together. You won't believe the number of times, the number of bits of paper I've scribbled this on, because it made sense in my head, but trying to get it down on paper was difficult. What I've tried to show there is really there's 4 different things which we need to think about. There are, within the person, you know, all of us as individuals have got personal characteristics, personal strengths, a certain degree of resilience which can protect us. But also within us, we've all got personal characteristics and risks. There are things which perhaps make us as individuals vulnerable. Think about the environment in its broadest context. As I said to you before, about it's not just about the physical environment, it's about people in that environment, it's about what they do, what they don't do. So within the environment, there's 2 options. There will be risks, and there will be particular characteristics that make certain environments problematic for people, but there are also things that can be done to that environment which will actually minimize those, which will change those. And the reason I got that there is because obviously that then gives us a number of different areas to think about how we can work productively with people to try and manage vulnerability effectively. If those factors on the right-hand side start overtaking those on the left, you've got increasing vulnerability. You know, when they're all in balance, that's okay. And you may find that people's personal characteristics, for example, will actually overcome some of the environmental problems. You will find that people's personal risks can be managed by environmental, so that all the four interact. But once it starts going from the right to the left, you've got increasing vulnerability. But on the other hand, if we can start to move things back into balance, or we can start to move things more towards the right, we can reduce vulnerability. And that's particularly important, of course, when that vulnerability actually might be harmful for the individual or for others. And as I said, I would put all of that in the context of time. In the context of time, that sounds good. Both context and time are both important there. So for me, because I tend to sort of think visually and like to have it there, to me that sort of tries to sum up what I'm trying to say in terms of what can we do about this? Yeah, where can we intervene? What can we challenge? What can we change? We talked about in the book about 3 different things which we think are important in terms of vulnerability. Recognising, responding, reviewing. And that brings together some of the things which I've already said. Recognise where there are risks. Recognise where there are actual or potential stressors. That needs to look at the individual. It needs to look at the environment as well. Respond. A number of different ways we can do that. We can increase personal capacity. I mean, those of you that are familiar with the Mental Capacity Act, for example, know that we're not meant to see capacity as something which is fixed. We're meant to try and maximise people's capacity. That may mean giving it information in different ways, rather than the standard ways. There are ways which we can make adjustments to the environment, for example. The whole concept of reasonable adjustments in the context of healthcare. What is it we can do which actually enables people to access and utilise healthcare on the same basis as other people? Changing the environment can increase personal capacity. Interestingly, there's a hospital not far from where I work, where there is a ward which is a sort of a ward specifically for people with dementia. And what they've done there is throw a lot of unnecessary routines out of the window, so that you're having to be up at a certain time, having to have your breakfast, having to have your bath, etc., etc. They've got food on the ward, so if people want to eat at different times, they can eat at different times. Staff, if somebody likes to sort of get up at 4 o'clock in the morning, they can get up at 4 o'clock in the morning. If they like to sleep they can sleep into lunchtime. And what they've found is that by changing that environment, changing the supports, actually it's reduced things like violence and aggression, it's reduced falls, because people are the environment is adapted to suit their needs, not to suit the needs of the service. So I think there are some examples there. The last one is about reviewing. Remember what I said, time is important, things change. Sometimes it's almost like, well, we've got a plan, that's it, let's stick to it. Things change and we need to be conscious and we need to be alert to how things change and review what we do at regular intervals. So, I've tried to pull apart vulnerability, get you to think about it differently. So what's some of the implications of this? I do think those of us working in education have got a duty to try and enable people to think more critically about vulnerability. Not use it just as one of those words that appears in things that we read, things that we write. What is it we actually mean? What are the implications? We need to consciously think about how we support people to develop strategies that can reduce vulnerability in practice settings. And there's some fantastic examples of things which people have done. It's quite simple things where it's actually reduced people's vulnerability. If somebody is vulnerable in terms of they can't communicate verbally, do we have pictures, photographs which people can point to? Very, very simple things. There are lots of things. I just use that as an example, but all of us need to look in our practice and say, actually, is there something which we could do? And we need to be supporting students to develop those strategies. We need to actually acknowledge the common experience of vulnerability. It was interesting when I was looking at pulling this together. You can imagine there was a whole range of articles that I came across which talk about vulnerability in, from pre-operative, peri-operative, through to disabled people, people with learning disabilities. I did find some about the vulnerability of nursing students, and I also found one about the vulnerability of nursing faculty as well, which was quite interesting. So I think it's also about recognising that vulnerability, making sure that the supports are in place for students, clinical staff and educational staff. Yeah, we need to support each other. And unfortunately, nurses haven't always been good at doing that. But I think we need to recognise that vulnerability is okay. And sometimes actually people, even in practice settings, people thinking they're invulnerable actually is quite problematic. So we need to think about that, and we need to think about how we support each other. I think the implications for research, I think first of all, we do need to further explore the vulnerability from the perspective of the people who we might consider to be vulnerable, but also maybe from the perspective of people who we wouldn't traditionally label as being vulnerable. Yeah? What does vulnerability mean to people who are using the range of services that we work in? We need to sort of recognise that, particularly if those of you that have ever tried to get sort of research studies through ethics committees, I think sometimes the researchers feel quite vulnerable as well at times. But we need to recognise that there are ethical implications to actually including people who might be considered to be vulnerable in the research process. But there's also ethical implications if we don't. Many years ago, when I was sort of first starting out on doing sort of funded research, we were doing a project looking at advocacy in older people in residential settings. And we were sort of advised, okay, perhaps not include people with dementia because consent's going to be difficult. But I'm eternally I wasn't at the time, but with hindsight, I'm eternally grateful for somebody on that ethics committee who had a background in working with older people with mental health problems, who said, actually, that's the group who most need advocacy. You've got to find a way to include them. So we had to develop strategies whereby if they could give assent, we could have independent observers in place and things like that. But that was really good because, if you think about it logically, think about things like abuse. If we don't examine that, if we don't look at it, if we don't engage with people who are potentially vulnerable, actually important aspects of their lives go unnoticed. And there's a danger that compounds, people's voices not being heard compounds it. Fact that, perhaps poor practice doesn't get examined. So we really do need to engage with that challenge to think about how can we look at this in the context of research. I think also, if you look at it from the, some of the benefits of being involved in research as well. People are vulnerable. I talked earlier about being vulnerable to exclusion. I think sometimes people are vulnerable to exclusion. If you look at the exclusion criteria, I hope it doesn't happen as much now, but certainly in the past, if somebody couldn't give consent or was deemed as lacking capacity, that was an automatic exclusion criteria, which then meant that some people who perhaps could have benefited from some interventions actually didn't get them. So we need to think about this carefully. I'm not saying just, go back to the days when we're not putting safeguards in place, but we need to look at it critically and we need to develop strategies. And, we do need to use a range of research approaches, including participatory and action research. I can sort of say I think it's really important that we look at vulnerability and I think we should do X, Y, or Z. But actually, if I went and talked to a group of people with learning disabilities or a group of people with mental health problems, would I come up with the same research question? Would I come up with the same strategy? I think we need to engage people from the beginning. I think, again, when you look at grant applications these days, most of them do have a section in them which says, about public and patient involvement, how have you engaged people in this grant process. Having reviewed a number of grant applications, there are some quite interesting responses to that section. You can really see the people who have engaged with people in a meaningful way over a long period of time, and the others who have got to that stage on that sort of box and thought, I need to put something in. One I came across many years ago, which was a lovely one. I think it was about doing an assessment with older people. And the box that had been filled in was, it's not felt appropriate, or it's not felt necessary to involve older people in this because it's an assessment that's going to be used by medics. people could be vulnerable to an assessment. We need to be engaging people. We need to think about in particular ways, how are people engaging with this? So I think there is an argument for working with people, not just working with people in a token way, but working with people in a meaningful way to try and make sure that that is taken forward. So, having started with Zen and the art of motorcycle maintenance, I want to finish with T.S. Eliot, one of my sort of favourite quotes. We shall not cease from exploration, and at the end of all our exploring, we shall arrive where we started and see the place for the first time. For me, I keep going back to this, and I keep learning more. I keep trying to look at it critically, and to look at it not just as an academic topic, but to look at it critically in terms of what it might mean in practice. In my practice, both as an educationalist, in supporting people to develop their nursing practice, and in undertaking research. I saw a comment yesterday, and I don't know where it was I saw it, but it said something about we get most of our learning from the questions, not necessarily from the answers. And so what I'd like, if hopefully you'll take more than that, but if you don't take anything else away from tonight, what I would ask you is to take away the need to question vulnerability, the need to constantly challenge both our own views and other people, and to think about what the implications are of that for the people that we support. Thank you.